This is the MyHeart.net podcast. This show is produced by Dr. Philip Johnson in conjunction with VitalEngine.com. Please welcome your host, Dr. Alain Bouchard, a cardiology specialist of Birmingham, Alabama, at St. Vincent's Medical Center, part of Ascension.
Welcome to MyHeart.net series on primary prevention. Today we'll be discussing lowering your cholesterol, a guide to preventing heart disease. And here's our excerpt with Dr. Martha Gulati, Director of Preventive Cardiology at Cedars-Sinai. Let's talk about cholesterol. Obviously, that's a big one. And knowing, when to treat, who to treat. So there's really, in the guidelines, there's really kind of two categories of patient that we've got to start, treatment, right away. And then maybe we'll talk about the third overall population category, which is, kind of using the risk stratification of the guidelines. But really comes to mind first the familial hypercholesterolemia. And then we'll talk about, the high cholesterol and diabetes. So let's talk about FH, for a while. I mean, I guess for us, we see, patients with very, very high cholesterol. That's LDL greater than 190. We see the heterozygous one. The homozygous, I guess the pediatricians see those because they develop atherosclerosis in their teens. I mean, that is such an incredible risk factor, FH.
Yeah, FH, and that's familial hypercholesterolemia. And, this is a genetic disorder. And I actually wish that they were more identified in the pediatrician's office, but I don't actually think that's entirely true. I don't think that pediatricians are actually following the guidelines to check cholesterol the way that we recommend. And there are clear guidelines that every child should have their cholesterol checked at least once to know if they fall outside of this category. And certainly in those people with a family history of premature heart disease, but we don't see it happening. And we even see it when we identify an adult with FH and we tell them your children need to be screened. And then they'll come back and say, well, the pediatrician told me they don't need it. And so now I just give their children an order to get their cholesterol checked. And if it's fine, okay, that's great, but at least they get it done. But yes, ideally, that's where it would be identified. And sorry, I got sidetracked. So now I forget what question you asked me about them, but go ahead, please ask me again.
Well, we know that I think we miss those patients, the patients with familial hypercholesterolemia. You get someone admitted for one reason or another, and they draw some cholesterol, and you get an LDL of 200, and they say, oh, your cholesterol is high. But, I think we miss those patients because the cardiovascular disease, it has such an impact, this high cholesterol. I mean, basically, in men, it ages you 10 to 20 years. And in women, it ages a person 20 to 30 years. It gives you, basically, if you're 20, it gives you a heart of a 40 or 50-year-old. I mean, it's tremendously impacted.
Yeah. And, this is where that, first of all, knowing your family history really helps us. Both did that first degree relative have heart disease, but how old were they? And, I told you having a male relative before the age of 55 and a female relative before 65, but I still want to know even their age. I want to know if they were really, really young in their 20s and 30s, because it heightens at least our thought process. Could you have FH? FH is a genetic disorder. You may carry one of the genes or two of the genes. If you carry one of the genes, you're at high risk, but if you carry two of the genes, you're at very high, you'll have heart disease. And so the one that carries the two bad genes, they're homozygous FH is what we call it. And they have these LDL cholesterols that are extremely high. And you're right, we often meet these very young people in the cath lab. And I took care of a few of these because in our lipid clinic, I had a 22-year-old. He had already had 4 myocardial infarctions by that point. And, it was a lifelong treatment since age 14. I think he was diagnosed, although he clearly had signs before that. And it's a really devastating disease, but yet a disease that we have so many great medications now to treat. Heterozygous FH is much more common. And this is where they usually have one bad gene that really does not help let them metabolize their LDL cholesterol normally. So usually the easiest way is when they get a cholesterol checked. If they're a kid, we'll see their LDL be above 160, and that is not normal for children. And if they have an LDL above 190 when they're an adult, that is not normal. And that should heighten our awareness. But yet there's so many people walking around with those LDLs who have never been told that they have FH. And they don't know how, just like that tells us not only their risk, but like we said, for their family, they should talk with their siblings, they should talk with their children, make sure their children have been screened. It doesn't matter how old those kids are, because sometimes they'll be identified even in their 40s and 50s, and their kids might be grown up. But it's important that they share this information, because they may have this genetic defect where they just have an abnormal LDL level. And yet again, the point is we have so many new medications now. At one point we didn't. We just really had, I'd say essentially statins and a few other drugs that didn't actually have outcome evidence. And even with statins alone, we couldn't get their LDL where we needed it to be. Now we have some pretty powerful medications and some new ones on the horizon that are hopefully going to change this. But key is diagnosis. And if we don't know that you have it, and if somebody isn't addressing it or sending you to a lipid specialist, then we will always suffer from the lack of awareness killing you, rather than something that we can do for you.
Yeah, definitely. So, this is the first category of patient that really need high intensity statin.
Exactly.
No doubt about that. I mean, the evidence is there. A second group with high cholesterol are the diabetics. I mean, I think if you have diabetes and if you have high cholesterol, it's like almost like you have coronary artery disease, proven otherwise, and they too require a high intensity statin. I mean, evidence is everywhere that you decrease coronary events, you decrease stroke, you decrease the need for PCI or coronary intervention. We could always consider the risk enhancers. So how long have you had diabetes, and so forth? Do you have proteinuria? How long have you been using insulin and so forth? So, I mean, that no doubt about that. But now we have the overall population, and this is where I think the ASCVD risk and that risk app and the calcium score can really help us identify patients with sufficient risk to merit treatment, and particularly with a high likelihood of net benefit. So, I mean, tell us about this, what the guidelines tell us. I mean, we have this patient population between 40 and 75 years old, an LDL that is between 70 and 189, I guess, otherwise they're FH. How do we classify, how do we treat these patients, Martha?
Yeah, so if, like we said, the high risk group, that let's clearly talk about statins first. And there, we want to get your LDL lowered by at least 50%. But then now we've actually even instilled LDL goals, and that, if we're not getting your LDL under 70, then there's other medications to initiate. If you're that intermediate risk group or that borderline risk group, like we talked about, or you have a coronary calcium score that somehow moved your risk stratified, or those risk enhancers, if you weren't lucky enough to get a coronary calcium score, but you have plenty of those risk enhancers, you might be in that intermediate risk group. So we certainly, at that point, if you're in the intermediate risk group, at least then you should be on moderate intensity statin. And we want to get your LDL lowered somewhere between 30 to 50% LDL reduction would be, it's actually a class 1 recommendation if you're in the intermediate risk group. So we should be doing that. And then if you're in that borderline risk group and you don't have additional risk enhancers, you may at least enter the discussion Where do you fall? Should we use a moderately intense statin therapy? It's certainly not wrong. Or maybe we do a coronary calcium score in that case. And just if there's no coronary artery calcium, maybe we hold off on medical therapy, but we keep a close follow up on these risk factors. And every year you need to have your ASCVD risk score calibrated, because of course we age, and so our risk goes up and our risk factors change over time. If you're low risk, I don't think that there's a role for statin therapy in that group. But lifestyle needs to still be part of the therapy, that we start talking about it, what's going to preserve you as low risk. It's not static. Nothing about our life, unfortunately, is static. As we age, some things get worse. Your blood pressure can get higher, and it's part of your ASCVD risk. And again, that's something that sometimes can be lifestyle, but is also a part of our aging. Cholesterol can get worse, again, based on lifestyle and sometimes genetics, and diabetes as well. So all those things enter your risk score. If they're changing, guess what? Your ASCVD risk score is changing. So it isn't a one and done type of deal. And again, those risk enhancers may appear as well. Like some things don't change, like your ethnicity obviously doesn't change, but whether you have kidney disease or not might change, whether you got pregnant and had some of these adverse pregnancy outcomes, whether you got diagnosed with those inflammatory conditions we talked about, or somebody did blood work and saw some markers that were elevated that they didn't do before. Again, that's why it's so important that this is an annual assessment.
So low risk, less than 5%, lifestyle, healthy lifestyle. High risk, greater than 20% lifestyle and at least moderate intensity of statin. And this intermediate group, the borderline and intermediate, between the 5 and 20%, we try to maybe personalize it according to their risk enhancers or even the calcium score. Because this is where you have to make the decision with the patient to go on. Yeah, obviously you do the lifestyle, but do you go on the statin or not? And some patients have gone on the statin, but they've had side effect. They're hurting all over. They're not so sure they want to take it. And this is where I think the calcium score, can really help. I have a patient, he's 63, very, very healthy. He was an incredible swimmer. His blood pressure was a little bit high at 140, and his cholesterol was also high with an LDL of 140. But very, very healthy, and had problem with the statin. In the past, it was kind of hurting him. And I did a calcium score, and it ended up, it measured at 182. And what's interesting is you can go in the app and you can look at obviously the calcium score helps you prevent your coronary event. And it can actually calculate the age of your coronary arteries. And I looked at him, and I kind of looked at this, and we went in the app together. And I said, despite the fact you're 63, because of your calcium score, you have the coronaries of someone who's 77 years old. And he didn't like that too much, because he's a physician. I mean, he's working out, he's healthy, but he could see that really it gave him a different perspective and maybe an incentive, to put up maybe with some of the aches and pain and start a statin. So I think it's important to have these discussions, and these tools are very, very helpful to, discuss and personalize medicine to each patient. It could have happened the other way as well. I mean, it could have been an intermediate risk and a calcium score of 0, where there would be really very little benefit, for the statin. So it's kind of interesting. But statin do work. I mean, we have like several trials with primary prevention. We have the mega trial, with pravastatin. We have the AVSCAP, TEXCAPS. Seems like such a long time ago, lovastatin. And finally, the more recent one, Jupiter, and the use of rosuvastatin, truly showing not only a reduction of LDL of up to 50% with rosuvastatin, but your risk reduction up to 44%. Very dramatic. Well, this concludes our excerpt on lowering your cholesterol. Our next chapter, we'll be discussing targeting diabetes to protect your heart.
To learn more from our team of cardiologists, please visit us at MyHeart.net. You can also follow us on social media by searching MyHeart.net on Facebook and Twitter. And be sure to subscribe to this podcast so you don't miss our next episode.